Okay, I'm going to warn you now, this is probably going to be a long video. So if you don't want to listen to the whole video, you can go to the link in the description, and this will be all in text on my website. So I've been reflecting a lot on healthcare recently, since my partner passed away, and I think that I've touched upon an interesting structural failing, particularly when we're talking about mental health, that is cultural and systemic, and what pretty much defines the power play between a service user and the service that they have been referred to. So I'm going to obviously be reading from my notes here. So they justify themselves, medical services justify themselves through the language of medical necessity. They identify disorders, classify symptoms, reduce risk, and provide treatment. But I would say that this account is pretty much incomplete. Psychiatry doesn't simply discover mental illness as a timeless natural object. It also helps produce the categories through which distress become visible, intelligible, and governable. So the central problem is not that something like psychosis, anxiety, or schizophrenia are unreal. It's that the institutions treating them organize these experiences in ways that fragment the person. They silence the meaning of symptoms and distribute responsibility so widely that the condition as a whole can disappear. So the central argument that I'm making is that the healthcare system generally treats different symptoms with a different specialist once they're presented. And if you're with the wrong specialist and you've got different symptoms, they can often be overlooked. You can be discharged without being referred to this other specialist. The continuity of care in between seeing one specialist and another can be a problem. So it's this atomization of specialization that becomes the problem, in particular to mental health, and how it's also segregated from physical health problems, and there's very little communication. It could be due to funding, staff shortages, or a number of other reasons, but the very structure of the way that we organise symptoms and practice medicine here in the UK makes the continuity of care very vulnerable to those situations because it's so atomised. So psychosis is real as an experience. But then we translate it into symptoms, paranoia, delusion, hallucination, thought disorder, or even a lack of insight. So once translated, the person's words lose their ordinary status as speech. We relegate that immediately. And a conviction is no longer answered as a conviction, but interpreted as evidence only of illness. So it's I find that when treatments such as cognitive behavioral therapy, cognitive behavioral therapy for psychosis are offered for psychosis, again, it's atomizing just the symptoms. It's only looking at the symptoms, and we're not dealing with the underlying mechanism that is generating the meaning, which is then interpreted as psychosis. CBT seems to find a base belief. We're then looking at how we're perceiving the world, and then given different skills to interpret that perception. But we're never really actually looking at how the meaning is made to get to the manifestation of psychosis. So we may be treating the symptoms, but we're not actually dealing with the underlying cause. And if we're talking about something like psychosis from a form of anxiety, say, we'll just give it something else to express itself as. We're not really stopping it. We're just saying this particular expression, we're going to look at it like this, but then it'll just it'll find something else to latch onto and express itself. And that's why I think that CBT really is too narrow when we're talking about psychosis, and it's something that would involve conjunction with medication as well. So basically what we end up with is hyper specialization, and we lose sense of one person with one overarching condition that's expressing itself. We lose sense of the cause of the problem by only focusing on symptoms and going to this specialist or that specialist depending on what we present to the clinician. So with the segregation of symptoms, this produces the segregation of services. Each service treats what falls within its remit, while the causal relations between symptoms become organisationally invisible. Anxiety may intensify hypervigilance, say. Hypervigilance may contribute to paranoia, poor sleep, may worsen psychosis. Medication may affect physical health. Relational stress may maintain anxiety. And yet each part can be managed independently from each other. And this allows everyone to say that their own task was completed, while nobody remains responsible for the condition as a whole. So we have this, through the atomization, you end up with a responsibility of irresponsibility just maximizing itself across the entire practice of mental health in particular. So the patient's narrative is displaced by the localization and classification of disease. It effectively, that's it's great for generating useful knowledge, but it also removes the condition from the person's entire life. So the more precisely that you classify each symptom, the less capable the system may become of understanding how those symptoms form one whole process. So you could be receiving several treatments, but the overall condition remains completely untreated. So, like, I look at this, particularly in the NHS and mental health in particular, as being a symptom of the way that we structure our culture and institutions in British culture is our emotional discipline, which is, you know, the stiff upper lip, which is self-command, class hierarchy, military discipline, moral regulation, you know, so distress was always expected to remain private, controlled, and non-disruptive. So psychiatry, as it's practiced here in the UK, seems to change the language, but it preserves the demand. So the moral command to control yourself becomes the clinical command to stabilize symptoms. So medication can operate within this structure as a technology of silence. So it may genuinely relieve the symptoms. It can stop hallucinations, it can stop paranoia, or at least dull them. But institutions can measure success through the quietness of those symptoms, reduce disruption, fewer crisis contacts, and, you know, and to make things easier to manage. But the symptom is suppressed before the conditions which are producing it are understood. So the Victorian discipline required suffering to remain hidden, and modern services may require it to become clinically manageable. So I need to offer you an alternative practice, one which is currently in Finland, it's in Norway, it's in a number of Scandinavian countries, and it's called open dialogue, and it doesn't rely on medication first and foremost. It doesn't exclude it entirely, but it tackles this problem of myopic specialization. It tackles this problem of the medical gaze, which is it sees this tiny little bit here, but it misses so much else. And then, you know, you're being treated by loads of people, but they have no cause, they have no whole cause to work with, to understand exactly why this person is expressing this problem. So open dialogue for psychosis, it doesn't treat it as isolated, as a defect that's just inside the individual, and it doesn't individualize the symptoms and then send it off to loads of specialists. The medical team immerse themselves into the person's family, their trusted network clinicians, the professionals around them, their friends, and they don't rush to a diagnosis. So uncertainty is tolerated and continuity is prioritized first and foremost. There's always a contact. So the difference is fundamental. So conventional services ask how to stabilize the symptomatic individual, but open dialogue asks what's happening in the person's whole relational world. How is the meaning made in real time? We're not just relying on talk therapy one-to-one. We're going to see how those stresses develop in real time, because we're going to put ourselves in that person's environment. So that you know, so traditional psychiatry separates the symptoms and allocates them to specialists, but open dialogue tries to preserve the links between fear, voices, sleep, conflict, relationships, and meaning. It attempts to restore the dialogue that psychiatry historically replaces with professional interpretation. So what we're doing is that we're allowing the illness to speak for itself instead of training the individual to talk about their mental health in a scientific language that then speaks back to the professional. We're going to let it express itself so we can see exactly how it's being triggered, where it's coming from, and then we'll tackle that. We'll be able to work on the meaning in the person's life in real time. So that's the alternative. That's what I see as the problem with service fragmentation. Now I'm going to talk about something which I think is a bit more pertinent at the moment politically, that we have companies like Palantir which offer federated data platforms which attempt to solve this problem of segregated services and atomization, where it's difficult to retrieve information between departments, which is a problem which wouldn't exist if we didn't, if we just looked at how our own culture influences the way that we practice medicine. We change the practice entirely by minimizing the amount of contacts and keeping the continuity more that the service user has to deal with when they're going through a crisis. So you got a company like Palantir that's offering federated systems that enter this fragmented landscape, and they appear to be solving a problem by connecting the data across the services. And so while they may be integrating fragments without overcoming the conceptual fragmentation that produced them, the platform can link a diagnosis, medication record, missed appointment, physical health result and risk assessment, but it can't by itself with Palantir's software, with something that it calls the ontology, it can't by itself establish that these belong to one developing condition. So the service fragments the person, the platform reunifies the fragments as an administrative project again, and this is not, but it's not the same as restoring the person as a subject. So the deepest irony, it's a temporal one. So the later technical solution reaches backward and redefines the earlier failure. So once the platform exists, the fragmented care is redescribed as a data integration problem, and the failures of continuity, interpretation and responsibility become failures of interoperability. The solution appears to have been made necessary by the past, while also determining how the past is understood. So this is kind of like effects configuring their causes, which seems to be the main issue with technological introduction, federated platforms and AI. That they're solving problems which could be resolved by changing our practice entirely. You're not going to be. We can't solve problems just by complaining and focusing in on single professionals when this is the epoch, this is the way power works, and now it's mutating into something else with the advent of federated data platform and AI technology that Palantir is offering to the NHS. So the platform formalizes the same categories that produce the fragmentation. The services then are supposed to reorganize around the platform and confirm its necessity. So institutions produce the objects they claim merely to observe. So that's the temporal irony, the reversal, that the eventual apparatus acts as an attractor shaping the conditions that later appear to have caused it. So the central argument there is not that mental health services are completely useless, or that we should abandon them entirely. It's that their legitimacy is completely weakened when they possess the authority to diagnose, medicate, and interpret resistance and restrict liberty while failing to preserve the unity of the person's condition. So a legitimate system, which in practice we'll see open dialogue, would have to treat the symptoms as connected expressions of a life, not as isolated objects, and maintain continuity of responsibility, integrate physical, psychological, relational and social care, and preserve the service user's speech as testimony rather than reducing it to just evidence of a disease. So the existing system is often capable of managing little fragments, but its failure lies in mistaking the management of fragments as the treatment for the person. And I think that this is fundamentally where so many people are falling through the gaps, because that fragmented system is so vulnerable to cuts and economic problems, people being off sick. So like, I don't think that you can look at this as just, you can't just look at a lot of failings as just down to malpractice, negligence, or the very structure of the services that we're allowing to run have deep cultural and systemic problems built within them that, when you look at something like open dialogue, the immersion of the team in the person's life, bring everyone into the conversation, would give you a much more complete understanding and better continuity, and it's much more manageable that way. But anyway, yeah. So that's my opinion on the power play of medical services, and why mental health in particular is prone to such failings with people.